My name is Ulrike Kuchler. I'm in the lucky position to be affiliated to two universities, to the Medical University of Vienna and the Medical University of Bern, where I conducted the study together with Professor Buser as a principal investigator the last 2 years. We focused in the recent study on sinus floor elevation and the loading protocol based on resonance frequency analysis. So when we go to the literature and we look for our experience in sinus floor elevation, it's impressive. Within the last 30 years, we learned a lot about sinus floor elevation, and this is a recent review in the Blows-Wand journal. They only included root-formed implants and studies having more than 10 patients reporting, and they report more than 16,000 implants in a grafted sinus. And they come to the conclusion, although we have different treatment modalities, it's a predictable treatment modality. So I focused on the simultaneous sinus floor elevation and did a search which of course is not complete, but just to give you an overview of which publications are we having the last years and how was the development in simultaneous sinus floor elevation in this time. The interesting for me is that when we look at the healing times, there we can see the tendency that we want to shorten, or the authors want to shorten the healing periods. And this at a very high level, so it has had no negative effect on the implant survival rates, as you can see on the right lower corner. So based on the experience in Bern and also the materials that changed the last years, Professor Buser came to the result we should start a study like reporting or looking for the loading protocols in simultaneous sinus floor elevation, because we want to shorten the healing periods. And therefore we asked the question, can we shorten the healing periods? And we based this on resonance frequency analysis. But when we plan a study, as Professor Wagner just said, we always have to think about the risk management. And I like this slide a lot because when you go skydiving, you can say it's very predictable these days because you have an instructor, you have a lot of experience. So skydiving, for example, is predictable because when you know your material. Yeah? And it's the same in sinus floor elevation or in the surgical procedures. You have to know your risks, you have to be trained, and you have to know how you can manage it when something goes wrong. So we always have to have the safety and the first line. And one of the backgrounds is always keep biology in your mind, because when you know how biology works, you can understand a lot of the things you're doing. And also for planning a study, you have to know what is the biological background, because you will be never able to really overstretch nature. This is also something that we learned the last years, which can prevent us from risks. So I put here on the screen, on the upper line, you see the remodeling, the regeneration of a socket wall after tooth extraction, and in the lower jaw you can see what's happening in everyday life in osseointegration. At time point 0, when we place an implant, we have a blood clot. Then after 4 days, the granulation tissue comes. It forms into woven bone and lamellar bone at the end. And what you can see on the very right-hand side is how a sinus floor elevation is remodeled after 6 months of healing. So when we have this in mind, and when we look how osseointegration is reflected, we can refer on implant stability. And therefore, it was very important to understand nature, because when you're at day 0, you will never get osseointegration. You always get a first time a primary stability, which is coming into a biological stability after a few weeks. So to measure the implant stability, we used the resonance frequency analysis, so the Austell device, as you can see here, from the procedure you put on the smart pack, as you can see on the left picture, and then you take your measuring device and it gives you a number between 0 and 100. So what we measure here is a surrogate parameter for implant stability. That's very important to say that. And it's a tool reflecting the bone anchorage, the implant in the bone. And what a lot of studies have reported, it's a good device to monitor and for the prevention and prediction of implant failure. Because we know that the implant, which is disintegrating, that the implant stability is steadily decreasing. And the University of Bern is quite experienced in the RFR measurements because it was used in previous study in Bern, and it convinced the people who were working with it there. So one study which was performed in 2009 by Michael Bornstein, also from the University of Bern, was an early loading protocol of implant placed in the mandible. They measured ISQ after 3 weeks, and the threshold level was 65 ISQ. So a threshold level is always very important in a study to make clear at what time you start with the loading. And what they could show that after 3 weeks, there were 96% of the implants which fulfilled the inclusion criteria for loading. They loaded the implants, and after 6 months, they had a 100% success and survival rate. And when you see this study, you always have to ask yourself, what about the long-term outcomes of these studies? And there was a long-term follow-up of these implants, and it was in a multi-center study together with Professor Morton. And they reported the 2 years results. And what you could see there is that based on the decision on implant stability, they had a quite high implant success and survival rate. So with this experience in mind, which was already done in Bern, we ask ourselves the question, so can we also screen the loading protocol in simultaneous sinus flow elevation? So therefore, at the time of implant placement with simultaneous sinus flow elevation, we measured the implant stability. After 8 weeks of healing, we did the second measurement. And as a threshold level, we had a 70 ISQ, which is a quite high ISQ level, just to be sure that we are not running a risk to lose an implant. And when they had over 70 of ISQ, they were restored. And when they had under 70, we recalled the patient every 4 weeks. And we are in the phase of making a follow-up of our patients after a 1-year healing period. To show you my study population, or our study population, which was included until last week this year. In 18 or 22 months, 122 people, our patients, underwent simultaneous sinus flow elevation. Actually, there are 9 patients in healing, and 32 patients were excluded from the study for several reasons, as you can see here. Some people didn't want to participate or missed the follow-up, or it was due to intraoperative changes. So I'm going to report you today 81 patients with 94 implants in total. So you can also see the distribution for male and female and the age. So what you can also see here that in the middle of Europe or in Switzerland, we are in the baby boomer generation, which means people are in the end of the 50s, beginning of the 60s in average. And the distribution of the teeth, which also might be from interest, is 70% molars and 30% premolars. To make it, to come to the results immediately is when we look at the ISQ levels, and you can see this here from a box plot. And you see on the left column, on the left box plot, the ISQ values at the time of implant placement, and then the follow-up after 8 weeks. And you don't have to be a statistician to see that this is significant after an 8 weeks healing period. But again, I want to tell that the primary stability that we get is a mechanical stability, just to keep this in mind. And when we look at the results all in total, which might be confusing now for you, but I have the feeling it just gives a very good overview, like where are we on our levels in this study. They're all around 70 also at the beginning of our study. And again, I want to say that in the operation, when you do the operation procedure, you only get mechanical stability. Because sometimes it was misinterpreted when people said, okay, when you have 70 at the beginning, why don't you go into loading? So, of course, we did not want to do this. We checked our patients after 8 weeks. So we can say 80%, more than 80% of our patients showed ISQ levels over 70 after 8 weeks. So you might ask the question now, what happened to the implants which did not reach the 70 in this 8 weeks healing period? And I think this is a very interesting topic, because here on this slide you can see how the ISQ levels developed. You can see that most of the implants started from a very low level, and some of them needed 18 weeks healing period, and these were 2 patients, female patients, which were edentulous. And I think this is also a very interesting observation. And of course, we have further analyzed this data, what might influence this increasing of the implant stability. And when we look at all the increasing implants, you can also see that the lower the implant is from its primary stability, the more it gains. This was very obvious, and we have a mean gain of 8.4 ISQ levels. And for us it was quite surprising, because it showed how some implants which are very low can bring up the stability within these 8 weeks. When we look at the increasing implants, we also have to look at the decreasing implants, because it's always stated that decreasing implant is at a high risk to fail. And what we saw is that some of the implants which show very high ISQ values at the beginning, that they decrease, but they don't drop under 70. And you might say now, okay, you should have monitored these implants, maybe they lose more. No, we did not do this. We went under reconstruction, prosthodontic reconstruction of these implants, and up to now we haven't seen any failure. So this is also a very interesting observation in this study. So again, when you look at the decreasing levels, the implants are not as strong decreasing as they're increasing. So in our everyday life and practice, we always want to have like guidelines, and many people came up to me and asked me, when I take a thicker implant, does that influence the implant stability? And therefore, I did the statistical analysis, and I can tell you that the diameter of the implant at the time of implant placement and 8 weeks follow-up did not influence the implant stability. We had no statistical significance in these calculations, which is a little bit contradictory to what we know from the literature. But we will see. We are doing another 20 patients, and maybe something changes here in this outline. So when we discuss on the primary implant stability, I was looking for the status reporting on the primary implant stability and different implant types, number of patients. And when we look at our data, we can say we are quite in the range of what is reported in the maxilla for primary stability. I screened the literature to find other studies that I can compare with my study, and there I found the study by Markovic, which was published in 2011, and they did osteotome technique. And they measured the ISQ values at the time of implant placement, as you can see here on the left side in blue, and after 6 weeks. And I put this data together with my data in a table, and why you have the question mark here is because we don't have a steady line. We have not measured the ISQ levels after 6 weeks, and it would be unfair to compare this data with each other. So, but what you can see here is that they also see an increase of the implant stability, and they went into loading after 6 weeks, which is quite astonishing. And the 2 years results show that they had an implant survival rate of 100%, which is also very remarkable. So when I put all our things together that we learned in the study is that up to now we show that 80% of the implants show quite high ISQ values after simultaneous sinus floor elevation after 8 weeks. Up to now, we have no implant loss in the observation period. All patients who had their ISQ over 70 underwent loading. Up to now, we do not report any troubles. Of course, we have to look at the data in a long-term level to be sure that this might be a possibility in the future. And we think that monitoring implant stability is an effective tool because with this device we could figure out patients which need additional healing period just to feel us comfortable when we go into loading of these implants. So I want to thank you for your attention, and whenever you have a question or you want to contact me or you want to know something, please don't hesitate to send me an email, and I'm happy to answer this. Thank you very much.
Thank you so much for this interesting study. I will start with the first question. You have only 2-stage implants. This means you have sufficient residual bone to get primary stability of your implants. Is all the things you measured depending on the sinus floor or only on the residual bone? Is there any correlation of the amount of residual bone and ISQ value?
Thank you for this question. It's obvious to ask this question, and thank you very much. To be precise, I want to do the calculations in a 1-year follow-up because I have a DVD 1 year after the sinus floor elevation, and I have a native DVD before sinus floor elevation. And depending on the implant position, depends the bone height, and I want to be very precise in these calculations. That's why I don't have the data up to now.
I have another question. The sinus floor augmentation was done, as I see on the, you give no information about this, as I see on the slides by BioOss or something, alloplastic material.
Yeah.
Do you believe that after 8 weeks of healing, the bone regeneration of the sinus floor influence implant stability in a sufficient amount, or is it only the reaction of the residual bone which are measured?
I think that after these 8 weeks of healing, we're sure not in a whole regeneration process of the augmented sinus. So this is ongoing after 8 weeks, that's for sure. And that's why I showed this study with human samples in the histology, where you can see lamellar and woven bone after 6 months. So after 8 weeks, this process is still going on. And I think it's more the residual bone that gives the stability, but only histological samples would answer this question.
When we now focus on the clinical influence of the ISQ measurement, you have no failure. I'm happy about this. But in my clinic sometimes happen some failures, even in sinus floor augmentation. Then you have, I asked for the influence on your really daily protocol. As I catch from your lecture, you have 2 groups. The group which starts very low, with ISQ about 40 or something like this, and you wait until it is increased to 70. That's one group. And the other group is where you had a high primary stability, and for whatever reason, the decrease of stability is very high-speeded, and you go under 17. Are these the two groups where you get information? For all others, you have ISQ above 17, and you load it after 8 weeks. Okay.
Yeah, I showed the increasing and the decreasing implant stability because it was quite interesting how steep they go. And we also have a lot of implants which stay in the same range, around 70, which have 70 at implant placement and go up to 72, but there's not a big change. So, I mean, we don't have clearly these two groups with decreasing and increasing. There are also a lot of implants which stay like stable over the 8 weeks period.
I agree. When you can detect two risk groups in your patients, that's okay. And it was only to focus where the clinical use for the everyday practice could be in this trial. And this is a risk group which has not sufficient primary stability, and the other one which decrease the primary stability so much that you cannot load it after 8 weeks.
Yeah.
I thank you so much.